Next speaker is going to be Dr. John Sleasman. John is he's professor of pediatrics, and he is the chief of the division of pediatric allergy and immunology. And he is going to speak to us about biomarkers. Welcome, John.
Great. It's great to be last. So I'm relatively new to Duke, and although I'm going to talk about biomarkers, what I really want to talk about is to give you some awareness about HIV infection among adolescents and young adults, because I, like Colleen Cunningham and Lisa Heito, have been involved with the Adolescent Trials Network for many years, and that network is coming up for a recompetition, and we're looking for new ideas in the management and treatment and prevention of HIV among youth. So I wanted to start by just talking about the epidemiology of HIV infection among adolescents in general, and to point out that youth bear a really disproportionate amount of their shares in sexually transmitted diseases, and I would include HIV infection in there. And there's a disproportionate share among minorities, particularly African Americans and Hispanics, with a high proportion of youth becoming HIV infected. And really about 25% of the new infections that occur in the United States are among youth between the ages of 13 and 24, and that number is actually skewed toward the 17 to 22 age group. So it's a major problem in youth because, A, they don't know that they're infected because they're relatively healthy. They can unknowingly pass the virus on to their to others, and it's become a major reservoir for viral infections in the U.S. as well as worldwide. One of the goals of the WHO and the goals of HIV treatment and prevention is to identify 90% of the people who are HIV positive, get 90% of them on antiretroviral therapy, and then get 90% of those to undetectable viral levels, because we know that's the level in which you have the best A, clinical outcomes, and B, the best chance of not transmitting it to your sexual partners. Well, we live in the epicenter of HIV infection, those of us that are in the Southeast, and I came here from Florida, and you can see the Florida numbers are pretty staggering in terms of the number of infected individuals, and particularly the number of new infections that are occurring per 100,000. And this is a major problem. It's a problem in men and a problem in young women as well. So I'm going to take a step back a little bit and talk about pathogenesis as it relates to HIV infection, and how our understanding of pathogenesis has a direct bearing on looking at the process. And this is something that everybody knows about. You have an acute wave of viremia in the first few weeks of after infection, before there's an adequate immune response, and this is a period of time you're highly likely to transmit the virus. And during this period of time, you're HIV negative. This is what gives the blood bank industry a nightmare. But during that period of time, you have a lot of immunologic activity going on that's really underappreciated. As we know, HIV has tropisms to both lymphocytes as well as macrophages, and they can infect through the CXCR4 and CCR5 receptor. And what I want to emphasize during this talk is is viral tropism and its effect on macrophages in particular. So between day 7 and 21 post-infection, about 60% of the memory CCR5 T cells in the Peyer's patches, mesenteric lymph nodes, can become infected, and particularly vulnerable are those Th17 cells that play a critical role in protection against intracellular pathogen and maintaining the gut mucosa. Those cells will become infected during this wave or tsunami of acute viremia, and they're never totally replaced. And this perturbation in the CD4 lymphocyte count is not really reflected in the peripheral blood. So the consequence of this, there's replication of virus in the mucosa, there's an inflammatory response, a loss of Th17 cells, and then there's this microbial translocation of endotoxin and bacterial products across the mucosa that then activates macrophages downstream. So we looked at this a number of years ago in HIV-infected children just to measure the extent of macrophage activation, and we used as a measure of macrophage activation soluble CD14, because if you look at the model that I'll show you in a second, soluble CD14 is shed when LPS binds to TLR4 on the surface of the macrophage, and then that can be measured in the blood. And we looked at it in healthy and HIV-infected infants, and we saw that there was quite a difference in the overall level. What we thought we would see is that if we put these kids on effective antiretroviral therapy, that this level of microbial translocation, the level of LPS measured in the blood of these children would go down with treatment. It made sense. You control viral replication, all good things happen. But what we saw was really just the opposite. If you look at this, if you look at this dotted line, that's the level of LPS in our healthy cohort, and we really didn't see a statistically different change in either our infants who were effective viral controllers or the infants who failed antiretroviral therapy. There was no difference, and what that told us, sadly, is that we really didn't see any difference in microbial translocation even after 2 years of therapy. So we came up with this sort of simplistic model where we would look at how does LPS activate macrophages, and this is my poor attempt at animation. So LPS binds to TLR4, soluble CD14 is then released into the plasma, and we can measure that. And then as those blood monocytes translocate into the tissue, they start to elaborate inflammatory cytokines like IL-1, IL-6, TNF-alpha, neopterin, and then they become these atherogenic foam cells that causes defects in the endothelium, and you have release of VCAM and C-reactive protein and all those sort of markers that we use for measuring endothelial injury. And this data was pretty much supported in the trials that were being done in HIV-infected adults. For example, the levels of soluble CD14 and interleukin-6 were the best predictors of overall mortality among HIV-infected adults enrolled in the SMART study. High levels of LPS and soluble CD14 correlated very strongly with the extent of HIV encephalopathy. And this actually is one of the problems among HIV-infected adults who have neurocognitive decline, because even if they're optimally controlled on antiretroviral therapy, they still have neurocognitive decline over the years. In addition to that, HIV-infected adults with elevated soluble CD14 levels had a 3 to 4 times higher risk of atherosclerosis and atherosclerosis risk compared to adults with similar risk. And we were able to show that HIV-infected men have a decrease in bone mass despite the effective use of antiretroviral therapy. That was Mulligan et al. That was an ATN trial we're calling. In addition to sort of these types of concern adjusted for risk, there were higher rates of coronary artery disease in men that were less than 34 years old and women that were under 44 years of age, predicting that no matter what happens to you, if you're HIV positive, your risk for coronary artery disease was going to be higher. And protease inhibitors were not the fact alone. The initial thoughts was because protease inhibitors increase lipid levels, that was all due to the lipids. In actuality, that's not true. It was the virus itself. So in addition to looking at soluble CD14 as a marker for macrophage activation, we also wanted to look at another macrophage marker called soluble Cd163, which is really the haptoglobin receptor, or a scavenger receptor on the surface of macrophages. It's involved in that cytokine cascade when macrophages become activated. And it's a good marker of HIV activity in early as well as chronic infection. And there's a number of papers that have shown that this is also a marker for neurocognitive decline. But this really hadn't been looked at in adolescents. So the next 3 sets of data I'm going to show you is my pitch, because all of the data that I'm going to show you were sub-studies of clinical trials that were done for a therapeutic reason, one way or another. But in the process of doing that, we had a biorepository, and we were able to ask retrospective questions about HIV pathogenesis from the biorepository. And at this point, I have to put on my glasses. So when we went into our biorepository, we had an observational study in a protocol called REACH, which was a study of adolescents that were just observed to see what was the natural history of HIV infection among adolescents. And among those were HIV-infected and HIV-uninfected youth, so that's our HIV-negative group. And we got 2 time points that we looked at, when they were enrolled in the study and 18 months afterward. We had individuals who had no antiretroviral therapy at 2 time points, because many youth decline antiretroviral therapy. And then we had youth that were treated for 18 months. And what you can see in these groups is that VCAM, which was a known marker of vascular injury, was elevated in our HIV-infected cohort, regardless of whether or not they were treated. So that gave us the basis. I was looking at one factor. We looked at a couple other things that were known to be associated with vascular injury, like C-reactive protein and interleukin-6, which really didn't tell us anything in that cohort. So we wanted then to address this in the context of a clinical trial. So we looked at this in a prospective study called ATN 101, which was an assessment of inflammatory markers associated with neurocognitive impairment. And what this study was trying to ask is, if you start antiretroviral therapy before CD4 T cell decline, can you improve neurocognitive function among adolescents if they're treated before their CD4 counts fall below 350 or after their CD4 counts fall below 350. So there's really 3 groups: an experimental group where we started it early, because this is back in the days before we started ARVs with normal CD4 counts. The standard of care group in this case were those individuals who did not initiate ART, who had 350 cells or higher. And then there was the other standard of care group was starting antiretroviral therapy less than 350. So treated early, not treated, and treated when CD4 cells declined. An important part of this study, which I'm really glad we did, was that we included a group of uninfected youth who were balanced for age, gender, and race. And these were youth between the ages of 18 and 24. They were predominantly male, and they were predominantly African American. The average duration for the infected group, and this is an important point, was only about 1.7 years. So these were all youth who were relatively early in their HIV disease progression. The average age was pretty much the same across the group, although our HIV positive group was a little bit older. And the reason for that, this was a 3-year study, and we drew a single blood study at the end of the protocol. So they were about the same age when we started, but they were 3 years older after that. As I told you before, they were mostly male. They were mostly African American. Their CD4 counts were relatively normal. They were higher in the uninfected group in terms of percent. But if you looked at the range of CD4 counts overall, the mean was around 651, which is really pretty good. Among our HIV viral load negative and viral load positive groups, they were also similar in age, but the fully suppressed ones had viral loads that were less than 50 throughout the study. So in this case, we looked at more than just 1 or 2 factors. We did a multiplex where we looked at markers of lymphocyte activation, such as gamma interferon, IL-2 receptor, IL-4, IL-10, soluble Cd27, IL-2, and IL-5. Markers of macrophage monocyte activation, like interleukin-1, IL-1 beta, TNF-alpha, And we looked at soluble CD14 and soluble CD163 among this group. We looked at markers of vascular inflammation like C-reactive protein, SCAM, ICAM, and MPO, and then we looked at one marker of bone called osteopontin. We did all this either by ELISA or by Luminex, and there were several of the biomarkers where over 40% of the patients and controls were below the levels of detection, so we didn't do anything that was at the low end of the spectrum. We looked at overall comparisons of these biomarkers amongst the viral outcome groups and using Bonferroni, and this is looking at the viral load negative and viral load positive group, and you can see that soluble CD27 is one of those markers that goes down but doesn't normalize when we compare it with our healthy control group. Interferon was really interesting because interferon was not only all over the board in our HIV-infected group, but it was also all over the place in terms of our HIV-uninfected groups. And soluble IL-2 receptors, or soluble CD25, was able to normalize in our HIV fully suppressed group, but remained relatively elevated among our HIV positive group. We looked at markers of macrophage activation, such as TNF-alpha, which was higher in our viral load positive group. We looked at GM-CSF, which really wasn't that much difference between the healthy controls and the HIV-infected. And soluble CD14 was also interesting because it brought back what we had already learned in our children, is that soluble CD14 is elevated and doesn't normalize in the viral load negative group compared to the viral load positive. Soluble CD63 was interesting because it also started to normalize, but didn't completely normalize after 3 years. So when we looked at the comparison of the vascular markers, the two things that fell out the most were the differences in ICAM and MPO, but again, I don't think that these differences were particularly significant. So we could go on and on with this slide after slide, bore after bore, and really not be able to learn anything about this. We did look at correlation networks. We looked at correlation networks from the standpoint of what we saw, which should be associations between different cytokines among HIV uninfected individuals. For example, IL-8 and IL-6 correlates very nicely with gamma interferon levels. TNF-alpha with IL-6 and IL-8. So we sort of saw relationships in our healthy control groups that we expected to see. When we started to look at this in all of our HIV-infected individuals, we started to see new networks of correlation that might be able to tell us about how macrophage and lymphocyte activation is relating to HIV markers of endothelial damage or other things. And we came up with some interesting associations. We saw, for example, that soluble 163 related to the directly with the levels of SVCAM and C-reactive protein. We saw that soluble CD14 didn't relate to those. As a matter of fact, soluble CD14 only correlated with interleukin 10. Among our healthy and HIV-infected youth, which is shown in these blue lines and in these dotted lines, we saw similar correlations with TNF-alpha, IL-6, and IL-8 with gamma interferon. And then we saw relations between MCP and IL-2 receptor in our healthy controls. But this really wasn't enough for us to really start to see what are the things that discriminate you from being an HIV-infected young adult versus an uninfected adult. So we went to principal component analysis to really try to figure this out. And in these studies, the uninfected are these gray dots, and shown in these circles is for the 95% confidence intervals. The green are the viral load fully suppressed, and then the red is the untreated group, and the blue is the youth who are being treated but who are still having ongoing viral replication. So what you can see here is that in terms of lymphocyte activation, there's not a whole lot of discrimination. There's some trends for the HIV negative versus the HIV positive groups, but really no discrimination, and absolutely no discrimination among the markers of cardiovascular infection or cardiovascular disease. In the monocyte group, we start to see discrimination, and the HIV infected group, those diagrams actually start to overlap. And when we start to look at all the biomarkers together, we can see some trend in the viral load negative with the uninfected group. So we did a principal least squares determinant analysis to see how could we actually start to differentiate between those things that weight toward infection and biomarkers of infection versus those that are healthy. And now we start to get a little bit better picture in that we can clearly see some discrimination in the HIV uninfected from the infected, whether they're treated or not. So we did a variance components, what they call VIP importance analysis, look at the things that were most weighted toward predicting whether you're HIV infected. And the three things that fell out with the strongest VIP score were soluble CD27, soluble CD14, and soluble CD163, with TNF being a distant third, or fourth, excuse me. And this held out that if we wanted to look at the biomarkers that were most predictive of whether you're HIV infected, the three biomarkers, by and large, were just as good as the 18 biomarkers for determining whether or not you could discriminate between a positive individual and an uninfected individual. So when we finished this single point study, we now wanted to ask a question about what happens in a prospective study where we randomized patients to antiretroviral therapy. And this now is using the ATN-061 study, which is a study that's called Prevention and Expansion of T-cell Subsets Following Complete Antiretroviral Therapy, De-Intensification to Atazanavir Monotherapy in youth with CD4 counts of greater than 350. And in this protocol, we had youth that we randomized either to an experimental arm, and in the experimental arm, we treated them with combination antiretroviral therapy for 48 with atazanavir boosted with ritonavir, tenofovir, and FTC. And if they were able to fully suppress virus to less than 50 at 24 and 48 weeks, we allowed them to de-intensify to monotherapy with atazanavir only and follow those patients for 2 years. If they failed to de-intensify, then they were just put back on a combination arm, and they were followed with a reduced schedule. And then we had a standard of care arm, and in the standard of care arm, we did not treat them unless their CD4 counts fell below 350, and then we put them on combination antiretroviral therapy and followed them for 3 years. Now, one of the nice things about this study is we collected just about everything known to man. We looked at their substance use, their toxicology screen, their soluble factors, their neurocognitive assessments at baseline. We looked at 24 weeks, we assessed their substance use and soluble factors, and then we did that at 48 weeks, and then after de-intensification, we looked at this period at increments over time. So what we were able to see among those individuals who either started antiretroviral therapy early or started late, independent of whether they de-intensified, their soluble CD14 levels remained elevated for all 3 years. And there was really no difference between those groups that started antiretroviral therapy early versus those that started antiretroviral therapy late. In those individuals in the soluble CD63 group, we did see a decline in the levels of soluble CD163 with treatment. And we interpret this that there's really two activation mechanisms here, one that's ARV sensitive and one that's ARV resistant, giving the two different pathways of treatment. We looked at this in comparison with T-cell subset analysis, and here I'm looking specifically at the central memory T-cell population based on CCR7 and soluble CD45RA, and looked at the relative expression of CD28, CD38, and HLA-DR. As we would expect in patients that fully control with antiretroviral therapy, CD28 goes up and 38 and DR goes down. But what was interesting to us, in spite of the fact that these patients had been undetectable for nearly 3 years, their levels of T-cell activation did not completely normalize when we